right, let's jump right in. Today, we're going to demystify three core components of the Braden scale that often get confused: activity, mobility, and the forces of friction and shear. Let's get to it. This is such an important idea to start with. Of course, turning schedules are absolutely vital, but a truly accurate risk assessment, well, that goes so much deeper. It really requires a nuanced look at the individual patient's condition, which, hey, is exactly what the Braden scale helps us do. So for this explainer, we're really going to zero in on these three specific subscales. Why? Because they're so often misunderstood or used interchangeably. But getting them right is absolutely fundamental to an accurate score and, at the end of the day, to keeping our patients safe. Okay, first up, activity. Now, this might sound pretty straightforward, but the clinical definition we need to use is actually very, very specific. And the key phrase you really got to latch onto is how often they get out of bed. See, activity isn't about how well a patient can wiggle around or shift in bed. It's a measure of their ambulation. It's about their big picture physical movement throughout the day. So when you look at the scoring, it's a pretty clear spectrum from 1 to 4. A 1, that's for a patient who is completely confined to bed. A 2 is for someone who's chair fast. Their walking is severely limited. As we move up, a 3 means they walk occasionally, maybe with a bit of help. And finally, a 4 is for a patient who's up and walking frequently, not just in their room, but outside of it too. But here's the kicker. Why does this actually matter? Well, it's all about time. The less a patient is able to get up and move around, the longer the duration of pressure on any given spot. It's a direct link, a straight line between their activity level and how long they're exposed to that risk. All right, let's pivot to patient mobility. Now, this is where clinicians can sometimes get tripped up because it sounds an awful lot like activity, but the difference between them is absolutely fundamental. Notice the shift in focus here? We're not talking about getting out of bed anymore. Mobility is all about what the patient can do while they're in a bed or a chair. Can they shift their own weight? Can they reposition themselves, even just a little bit on their own? So let's just put it side by side. It's really this simple. Activity is about ambulation, how often they're up. Mobility, on the other hand, is about their control, how well they can change their own position. It's a crucial, crucial distinction. And this right here is the aha moment. Just think about it for a second. A patient could be completely bedfast, that's an activity score of 1, but if they can independently and frequently reposition themselves in that bed, they could actually have a mobility score of 4. They are two completely separate assessments. And if you look at the mobility scale, it perfectly mirrors this idea. At the bottom, a 1 is for someone who is completely immobile. A 2 or a 3 shows they have some ability, but it's limited. And a 4, the best score, is for a patient who has no limitations at all. They can move and reposition themselves whenever they need to. So what's the bottom line here? While activity tells us about the duration of pressure, mobility tells us about the patient's ability to redistribute that pressure. It's essentially their own built-in defense system against injury. Okay, let's tackle our third and final piece of the puzzle for today: friction and shear. I like to think of these as the invisible forces that can cause just devastating damage to tissue. Now, friction, that's the one we can often see, right? It's the skin rubbing against the sheets. But shear is the real hidden enemy. It happens when a patient slides down in bed. Their skin might stick to the sheets, but their skeleton and deeper tissues keep moving down. This stretches and can literally tear the blood vessels way down below the surface. What's interesting here is that this subscale is a little different. It only has 3 levels. A score of 1 means there's a definite problem. The patient needs maximum help to move and they slide down a lot. A 2 indicates a potential problem. They might move feebly or slide sometimes. And a score of 3, no apparent problem, is for a patient who can move independently and keeps a good position. And this is such a sobering thought, but it's absolutely vital to understand. The damage from shears starts deep, deep inside, long before you would ever see any redness or breakdown on the skin's surface. By the time it becomes visible, the injury is already really significant, and that's exactly why assessing this risk is so critical. Okay, so we've broken down all 3 pieces. Now for the final section. Let's put it all back together and see how it creates the complete clinical picture. The real question is, how do these factors play off each other? What's the story these 3 scores tell us when we look at them all together? This is how it all connects. Think of it like this. Activity tells you the patient's exposure time to pressure. Mobility tells you about their ability to reposition and fight back against that pressure. And friction and shear tell you about the underlying integrity of their tissue. Each one gives you a unique and essential piece of the puzzle. And that really brings us to the most important takeaway of all. Scoring the Braden scale accurately isn't just about filling out a form or checking a box. When you really understand these components, you see it for what it is, a structured, clinical assessment that is absolutely vital to patient safety. So the question to leave with is this: are we just completing a task, or are we truly assessing the risk?